The case study I have was a family who presented with a young daughter who had frequently been complaining of pain in her knees and her fingers, more severe in the morning, and when waking up from naps. She had experienced swelling, warmth and redness, along with fevers on and off for the past few weeks, and they weren't sure what was going on. They brought her in. Blood testing showed a positive RF factor, which led the diagnosis to be juvenile rheumatoid arthritis with a subtype of polyarticular, which means it was in more than 5 joints due to the many fingers affected as well as the knees. So that is where we are at for the case study portion. I chose to look into the different treatments of juvenile rheumatoid arthritis. This first article was titled Current Treatment of JRA. It showed the current treatments that are used most with different JRA cases. Basically, for all the patients, the goal of the therapy is to decrease the chronic joint pain and swelling, to allow them to improve function, normalize their growth and development, and just kind of have a normal everyday life as far as ADLs are concerned. They also want to prevent eye damage, for it can attack the damage and cause uveitis. The first line of therapy is NSAIDs, the non-steroidal anti-inflammatory drugs, as well as DMARD, which are disease-modifying anti-rheumatic drugs. They're usually used in combination. There are also corticosteroid injections that can be done, such as into the knees or the joints that are affected the most if it's not functioning properly. There have been findings that show that the use of some of the adult rheumatoid arthritis drugs are possibly going to have some effects on the JRA or be safe for use, such as Intercept. Those are still under research though, because they have not been able to test the long-term findings yet. For patients that have a poor prognosis, such as difficulty with ADLs, or they're really having trouble functioning, they usually will use methotrexate as the first line DMARD. If that does not work or it becomes unsuccessful in treating the inflammation, they will now try Intercept, but it should not be used until methotrexate has failed due to the questioning of the toxicity over time. The article really did go into great detail of the traditional therapies that are used now and how they work, what they are usually used as far as first line, second line, third line. It really kind of gave you an oversight of how you would treat this patient with the JRA initially. It also showed us that we need to refer properly our patients to rheumatologists, ophthalmologists, to make sure there's no eye damage involved, as well as possibly going into physical therapy, which this article didn't go in depth about, but I would like to look and see what the different physical therapy can do as far as assisting with decreasing the inflammation. But basically this article went over that NSAIDs and methotrexate are really the main drugs that are used in today's treatment of JRA.
One question that I had about the corticosteroid injections is I know that I did get one in my knee when I was playing soccer, and well, I was given a cortisone shot, and it was supposed to work right away, and the doctor actually told me I should be able to do all of the movements that I was unable to do due to the pain within a couple hours, and I was going to a tournament that weekend, so it was my last resort of any help to be able to play to at least a small degree of as good as I could have played without it. And within a couple hours, I went to try and do these different movements, and it hurt just as bad, if not worse, because now everything was inflamed. So it didn't relieve the pain until 4 to 5 days later, and I wanted to know if this was something that these patients felt that they felt relief right away, or is it something like that where it did take as long as mine took to kind of even have some relief, because I know this is like a daily pain. And do they say how long that those shots actually last? Because my shot actually I was given the shot 2 years ago, and my knee has not hurt since.
This article did not actually go into detail on how exactly the corticosteroid cortisone shot works pathophysiologically, but I do know from experience, my sister got a shot. She has JRA. She got a cortisone shot about 3 months ago. It did work immediately. Like that next night, it was like new. She had been limping for days because of the pain, but it happened like within an hour. That shot lasted her about 2 months, and she's very active. She plays on the softball team, so it could last longer for different people, probably if they're not as active. And then she did get another shot. I know that it says within days, so I'm assuming that just differs with every person on how it affects them. But I know that I was talking to a doctor at one point, and they said it depends on the cause of like the need for the cortisone shot. With the JRA, it's just the inflammation, so it's not an actual injury per se. There's not like tendon or ligament damage. It's just the inflammation of the joint. So they are comfortable giving the cortisone shot. One of the doctors did tell me under like a certain age, I think it was 18, 19 years old, he doesn't really feel comfortable giving cortisone shot if it's for an athletic injury, because a lot of times you can just cause more damage. So it's possible that it could have been like a ligament or a tendon damage, as opposed to just inflammation of the joint. So that could play a role in how the cortisone shot works and how effective it is. This article talked about the macrophage migration inhibitory factor and then the role it plays in the inflammation process and as well as autoimmune conditions. It was an original research article that was a prospective study clinical trial. The independent variable of the actual study was the different levels of MIF in the patients that were studied. They had RA patients versus healthy patients as control and studied the different levels of MIF. They later looked at the dependent variable, which was the joint and radiologic damage in the patients found over time. The study was done over a 20-year period at the Department of Rheumatology of Radboud University of Medicine, that was in the Netherlands, and it had 277 patients that were met the RA criteria, as well as 277 healthy individuals that they compared the joint damage in. The kind of preface to this article was that the MIF is a cytokine that had been found to be a regulator of immune processes. They believed it could play a role in autoimmune conditions such as juvenile rheumatoid arthritis and regular rheumatoid arthritis adult version. The MIF was expressed more abundantly in the synovial cells in the patients with the RA, and they believe this is linked to the MIF levels. So they believe that the MIF could have a role in the pathogenesis of RA. It was found that the neutralization of MIF delayed the onset and lowered the incidence of arthritis, as well as anti-MIF treatment during rat studies resulted in decreased adjuvant arthritis clinical score and a decrease in macrophages and T cells in the synovial compartments, which can further increase inflammation. The treatment with the anti-MIF monoclonal antibodies showed that it blocked the interleukin-1 regulation of inflammatory processes, so with the blocking of that, it could help also decrease inflammation. Pretty much the study found that there was a few areas where it did have significance, and that was the variants of the gene 173 and CATTS of the MIF. It showed that with increased levels, there was increased inflammation, and it found that homozygous CATT and any 17 or 173 was related to increased joint damage after 6 years due to that increase of MIF in the synovial fluid. The article was pretty hard to understand. You really had to dig into it because it was pretty confusing with all the different genes and genetic components involved in this study. But it overall was pretty interesting once you were able to kind of decipher what it was saying, because it put forth a need of further studies we can do using anti-MIF treatment as a possible treatment for JRA or RA. So it could be beneficial in the future with further studies for our patients as a new kind of wave of treatment that could become pretty much essential in the future. What I did was looked at reversible lymphomas associated with Epstein-Barr virus that were occurring during methotrexate therapy in patients with rheumatoid arthritis and dermatomyositis. I'm going to focus on the rheumatoid arthritis portion of it. It looked at retrospective case studies. There were several different patient studies they looked at. But basically what they were looking for is that there had been reports that there was an increased risk of lymphomas in patients with rheumatoid arthritis, but they weren't sure if it was due to the immune therapy methotrexate or the disease itself. These case studies kind of looked at that. They did ultimately find that the methotrexate therapy indeed had a role in the development of the Epstein-Barr associated lymphoma in the patients with rheumatoid arthritis. There was a case where a patient had herpes zoster as a side effect, so they took them off of the methotrexate. As soon as the patient was off of the methotrexate, there was disappearance of that tumor over 6 months after that withdrawal of the methotrexate therapy. There was not development of lymphoma when the patient with psoriasis was on methotrexate, so they believe that there is possibility of other factors contributing as well in addition to the methotrexate therapy with RA. The patient does usually have an elevated frequency of the Epstein-Barr virus infected B lymphocytes, and then there's also a T cell defect in the specific suppression of EBV with the rheumatoid factor, the arthritis. So they think the methotrexate is kind of triggering something pathophysiologically that's causing this to happen in rheumatoid arthritis, since it did not cause the lymphoma in the psoriasis. The article really was interesting, and it really emphasizes that we need to know about the treatments we're giving our patients and complications that can arise from it. It really went along to give a good description of this complication of the lymphoma and kind of talk about how they think it is interacting with different portions of the rheumatoid arthritis. It should enlighten us to keep an eye out for this when we're treating our patients with methotrexate, both RA and dermatomyositis, as well as possible other tests, other diseases, to go ahead and do routine testing for these kind of complications to monitor them and possibly catch them early on. If the patient that we have does, as a matter of fact, develop a lymphoma while they're on this therapy, we should discontinue the therapy to try to reverse the lymphoma. So overall, this was a really good article. The article that I did for this website was on genetic variants with anti-tumor necrosis factor treatments in rheumatoid arthritis patients. Basically, rheumatoid arthritis, it doesn't always respond to the treatments that are done for it, including tumor necrosis factor antagonists. So this study looked at whether there was a genetic variation in the genes of patients that encoded for the proteins P38, which signaled the response of tumor necrosis factor antagonists. The study looked at 1,102 patients with RA receiving anti-tumor necrosis factor therapy, and they were genotyped for the 38 pairwise single nucleotide polymorphisms, or changes in DNA, of the P38 network, which plays a factor in the tumor necrosis factor antagonist mechanism of action. There was a regressive analysis done on this genome to kind of see how if there was a change in the disease activity score across the 28 joints for the patients with the rheumatic, and that is abbreviated as DAS28. In the study, basically what was found is that Of the 38 single nucleotide polymorphisms or alterations in the genetic components of patients, 7 of these in 5 genes were impacted by the growth, the joint activity of the disease at 6 months, with a significant alpha of p less than 1.1. They also found that the single nucleotide polymorphisms in the genes from every level were associated with response to anti-tumor necrosis factor therapy, suggesting that the pathway does influence outcomes. The article was very confusing because it was very complex in its own nature, so I really had to dig in and try to understand what they were telling me. I still don't know if I understand everything it says, but I understood a good bit of it to be able to see what the main point of the article was. And that was that there is genetic variation in patients that does affect the anti-tumor necrosis factor treatments in rheumatoid arthritis. More research would need to be done on these factors and the significance of difference from patient to patient. Basically, we can use this as we learned in cancer. There is genetic profiling that's becoming a major part of treatment, and this could be one more part of that. The article I did my voice ed on this time was on a new possible treatment for rheumatoid arthritis called mangiferin. It basically went into the fact that there has been evidence showing that fibroblast-like synovial cells play a crucial role in the joint degradation and inflammation in rheumatoid arthritis. They believe that this happens primarily through the inhibition of pro-apoptotic pathways, so they've been looking for possible medication that could help with this, but the previous ones that they had increased side effects and cytotoxicity effects because of the large-scale proliferation. It was having a lot of collateral damage. This drug, however, though, is naturally occurring, so it has excellent anti-inflammatory and antioxidant properties, but it also doesn't have the cytotoxicity side effects. It does have that strong pro-apoptotic effect that works towards the synovites to prevent some of that inflammation that occurs in rheumatoid arthritis. The study is being done on mice at this point. It has not been done on humans, so the study did conclude that the compound could be useful in rheumatoid arthritis treatment, especially with targeting the NF-κB pathway, which was intra-articular therapy that was shown to be effective in animals. They said that with the natural occurring factor of the mangiferin, that it could be proved to be successful in alleviating RA symptoms and could be a drug to add to the treatment of rheumatoid arthritis. If this drug were to come on the market and prove to be effective without the side effects that they don't believe are going to be present, it really could be another kind of punch to add to the list of drugs on top of the methotrexate and loxapine, folic acid, those kind of medications that patients are on right now for rheumatoid arthritis. So it could be just another tool in the belt. It was a good article. It really was pretty concise and interesting and not difficult to read. So that was what the article was about. The article I chose talked about growth hormone therapy on patients that are receiving glucocorticoid steroids for their JRA. It was a prospective study that took 14 individuals who were on prednisone with systemic juvenile arthritis, and it looked at the effects of growth hormone therapy on their bone mass, height, weight, and fat mass levels. The inclusion criteria: the patients had to be over 3 years of age, pre-puberty, and then had to be within normal standard deviations, 1 to 2 standard deviations of height and weight based off the normal, to make sure that it wasn't already out of the norm for them when looking at the results. The severe growth retardation that can be found in glucocorticoid steroids is one of the major side effects, as well as increased weight and fat mass, which can be detrimental to a patient who's a child going through adolescence and puberty and in a social area. So it took these 14 patients, it treated them for 1 year on the growth hormone. It showed that they had 1.4 units per kilogram per week of factoring how much growth hormone they got. They did that for 1 year. After that year, they took them off the growth hormone. They remained on the prednisone. The treatment showed that the growth hormone increased the insulin-like growth factor and the insulin-like growth factor binding protein, which caused an increase in height and lean body mass increased by 12%. After they stopped the growth hormone therapy in those 2 years, they found that the height velocity fell to the pre-treatment levels and that weight and fat mass increased markedly while the patient was on that prednisone. They also found that the bone formation and resorption markers were increased during treatment and fell as well to pre-treatment levels. This result suggests that growth hormones may partially counteract the adverse effects of glucocorticoid steroids and help the patients to kind of cope with these effects that as they're on prednisone or glucocorticoid steroid during their arthritis treatment. The article was really easy to understand. It was actually very interesting to see how it could treat the possible side effects of their meds to assist them during their adolescent stage, where social implications of being shorter or heavier can be detrimental to them. And I think that this is something that we could really use in our practice. For if we have patients that are undergoing treatment therapy for a chronic arthritis as a child, we can try drugs like this, like growth hormone, to try to prevent some of the side effects that they might undergo.